Let's start real quick. My name is Tuesday Dyer. I am the executive director here at CFC International. We have with us our program manager. She is in a part-time role with us. That's Ashley Genlin. She's also on this call this evening here in the United States. We are very excited to have Dr. Bradley. Dr. Bradley, Dr. Miller, Dr. Bradley Miller. Dr. Miller has been involved with CFC International for over a decade now. He has seen many of our CFC patients. He's participated in our conferences. So some of you have even had an opportunity to meet Dr. Miller at our conferences. And Dr. Miller was very instrumental in the growth study that many of our families participated in, almost a decade ago now. So he's going to talk a little bit about that this evening. But Dr. Miller completed his pediatric residency and pediatric endocrinology fellowship at the Mayo Clinic in Minnesota. He is the professor in pediatric endocrinology at the University of Minnesota and has been a member of the division since 2003. Dr. Miller has an interest in the role of growth hormone and insulin-like growth factor systems in normal and abnormal growth in children. He has interest in the growth and development of children following adversity, including cancer and its therapies, fetal alcohol exposure, international adoption. Dr. Miller is also interested in the endocrine aspects of abnormal, oh, that is me, I apologize, glycosylation in children with congenital disorders of glycosylation. And Dr. Miller is also interested in, I cannot say all of these words, Dr. Miller, androchondroplasia and other skeletal dysplasia conditions. Dr. Miller is with the University of Minnesota Health Fairview. We are very, very excited that he's here because we've had families ask a lot of questions about growth and puberty in a number of areas in CFC syndrome. He's going to talk mostly about growth this evening. We actually are going to have Dr. Miller come back with us in a couple of months to talk about some other areas surrounding endocrinology, specifically puberty and conditions within CFC syndrome. And Dr. Miller is also a new member of the medical advisory board of CFC International. So I failed to say that from the very beginning, but we are very excited that he has agreed to volunteer his time to come on our medical advisory board and provide us the expertise that we need in endocrinology. So without further ado, Dr. Miller, please take the stage.
Thank you, Tuesday. That was better than my mom's introduction, so I really appreciate it. Uh, for those of you who aren't aware, I just flew in from Atlanta minutes ago, so my hair's on fire, and as I told them, my arms are tired. So um, today, I'm a pediatric endocrinologist, and growth is my interest and expertise. And what I've tried to do in the 23 years now that I've been at the University of Minnesota is to try and understand and apply our understanding of growth to the growth in different rare conditions. And so, the beginning of my talk will focus a little bit on what is typical growth, how do we classify growth in terms of the growth curves, and we'll talk some statistics about standard deviation scores and kind of where does somebody fit on a curve and how do they compare to other individuals. I'm going to give a couple examples of work that our team at the University of Minnesota and elsewhere has done to try and understand growth in some rare diseases. And then what Tuesday was talking about, my work with Pilar Magulis and Carrie Johnston and others with the partnership of the CFC families to understand a little bit about growth in CFC. I have some puberty stuff at the end, but as Tuesday mentioned, that could be part of a future seminar. I do want to talk a little bit about how puberty impacts growth tonight, but focus mostly on growth, and then leave a lot of time at the end for some questions that people will put into the chat that you want Tuesday to read out to me and be discussed as a group, and then time at the end when the recording is off to talk more. So feel free to put them in the chat, but I can't see them on my screen, so I won't answer them until later. So let me just click on the right buttons to advance my own slides. These are my disclosures. I am a consultant for a number of different companies that are developing therapies for children with rare diseases. I receive research support as well as consulting honoraria. I will talk a little bit about off-label uses of medications and medications that are in development or not yet approved in some regions, but not very much tonight. So my learning objectives are to really focus in on cardiofaciocutaneous syndrome and its impact on growth. I'll talk a little bit about the risks and benefits of growth hormone therapy, what little data we have in children with CFC, but a little bit more about what we know about the broader risk and benefit of growth hormone therapy in the broader population of children who have received it. For background, I'll talk about the normal growth in puberty, some impact of the CFC syndrome on growth in puberty, and then some possible treatments for both abnormal growth and puberty. And again, focusing mostly on growth. So, how big are you is a common question that we ask our kids. And this is my daughter when she was 3, and we were at diabetes camp. She's now a 24-year-old labor and delivery nurse, Miss Becca. But how do we measure it? We use measuring devices. Some of people call them torture torture devices, particularly in the little children where we're trying to measure length and holding them very carefully on the table and measuring them very carefully. And one of the biggest challenges when we're trying to decide if a child is growing well is whether or not they were measured well, whether they were cooperative, whether the team that was doing the measurements did it properly. And in many primary care situations, children aren't measured very well. And so we sometimes don't recognize that the measurements are poor until we try and plot them and see if a child is growing well over time. After about the age of 2, when children are mostly standing up, we'll start doing standing heights rather than lengths. But that can be later in children who aren't able to stand because of low muscle tone or other health issues. And so sometimes we have to plot a length on a height curve. After the age of 2, we're typically using height to judge a child's growth, linear growth. And so it should be done with a stadiometer where a child is standing appropriately. And in our clinic, we measure kids 3 times just to make sure that we're getting the best measurements that we can. But I think it's important that as parents that you advocate to have your child measured properly, and if you don't think it was done well, to ask them to try and do it one more time to get better data on how a child is growing. So how do we know what is average? And this is based on reference data from general populations, and this can be global data, which is the World Health Organization WHO charts, which are used for smaller children. It could be country specific, depending upon what country you're in, and there may be condition specific data, and we'll talk a little bit about that and how it compares to the either country specific or global data. And then what do we consider normal? And normal is a statistical definition based upon the population. It's generally accepted as the mean plus or minus 2 standard deviations. So children who fall between the 2nd percentile and the 97th percentile are considered to have growth that is within the normal range. If we look at the US male height equivalents, and sorry, I'm doing this in a US centric perspective, these numbers do differ, particularly if you're in different countries like the Netherlands or Denmark, where people are unusually tall, or some of the Central American countries where people are smaller. But in the US, the average height for minus 2 standard deviations would be 161.5 centimeters. And that's, I think, 5'3.5". I'd have to do the math quickly, but for a female, it's 150.1 centimeters or 4'11". Compared to the mean, which is 5'9" and a half for men and 5'4" for women. And so just gives you a perspective in the actual numbers of where are we looking. And the important thing to think about with percentiles and standard deviations is number one, as you look at this cartoon, um, somebody is supposed to be at every point on this distribution. So it's normal to have a child who is at the first percentile, and it's normal to have a child at the 99th percentile, but smaller numbers of children should be there than in the middle of the curve at the mean. And the further you get away from the mean, the more unusual it is for somebody to be in that category. And when we're thinking about growth, when we find children who are below -2 standard deviations, and particularly if we find them below -3 standard deviations, we start to be more concerned about a genetic cause of their growth abnormalities. Also, at the far end of the upper end of the curve, children with unusually tall stature. If they're 3 standard deviations above the mean, it's more likely that there's a genetic condition affecting that. Within the middle of the curve, and even in the lower ends, but not the severe ends, there's a lot of different genetic causes of us being different in terms of our growth, and there are also a different number of different nutritional or chronic disease features that can impact our growth and can impact where we live on the growth curve. It's also important to know that kids grow at a very standard growth rate. And so this is a curve from 1985 where they look at the speed of how children grow. And what you can see is that they don't show the curve before the age of 2, but it actually is falling from a very fast rate after children are born until 2, and then slowly it falls between the ages of 2 and puberty. And then there's a group, this red line is the early bloomers, the average for the early bloomers. This line is the late bloomers, and this big peak in the middle is the boys who have average timing of puberty. So essentially, you grow at a steady rate, and then you slow down until you have a pubertal growth spurt, and then you're done growing. Your growth plates fuse. It's important to notice that children slow down right before puberty and then have this big spurt, and that about 15% of the total height is achieved during that pubertal growth spurt. And so when we think about helping children grow, we want to help them grow before the growth spurt because we have a limit before the pubertal growth spurt because we have a limited amount of time to do it once that puberty happens. And also your body is a little bit more resistant to some of the interventions that we might think of during puberty. The other thing to think about on the growth velocity curve, and most people will never see a growth velocity curve unless they're seeing a pediatric endocrinologist, but it is true that kids really do grow in spurts even when they're not in puberty. So it may be that a child is growing 3 or 4 inches a year, and then they're growing an inch per year, depending upon the intervals that you look at. So um, it's normal for this to have dots all over the curve and not just follow a channel. Whereas on the typical growth curve, we expect kids to follow in a channel for the majority of their time on the curve. So what is normal growth for your family? So when we think about the genetics of growth, there's a significant component to how tall are your parents as to how tall you will be. So there is a calculation called the mid-parental target height, where you take mom's height and dad's height, you divide it by 2, and in boys you add 2.5 inches, and in girls you subtract 2.5 inches. So if you have a father who is 6 foot tall and a mother who is 5'4", which in Minnesota this is pretty typical, um, you would do the average and you would say for a boy you'd add 2.5 inches, and so you'd get 5'10.5", and so that boy would be just above the mean of 5'9.5". And for a girl you'd have 5'5.5", and so she'd be just above the mean of 5'4". And so when you look at that prediction, that tells us that boys born to parents that size would typically be 5'10.5", ±2 inches most of the time. So there's a typical range of about 4 inches above and below that. And in wider variability, you can see as much as 8 inches difference, but most boys will fall within that 2 inches above and below. So target height is 5'10.5" for this boy. So how do different conditions affect growth, and I'm going to focus on rhasopathies, of which cardiofaciocutaneous syndrome is one, and I'll talk a little bit more about that later. But when we look at studies of rhasopathies in short children, we find that when we look for rhasopathies in short kids, we find that there's a significant number of children that have positive testing for rhasopathies. And so this is 814 girls with a mean height of -3 standard deviations. And there were a significant number of copy number variations, some chromosomal abnormalities, and variants in genes. And this is the large population. But 46 out of the 361 that were identified as having short stature were found to have about 12% of them had rhasopathies. So abnormalities in the signaling pathway that includes PTPN11, neurofibromatosis, and the different genes that cause other rhasopathies, including cardiofaciocutaneous syndrome. So it's important to recognize that with rhasopathies, not only do we see growth concerns, but we also see facial differences and congenital heart disease. And so that connection for us as endocrinologists or geneticists, the connection of growth concerns with other findings is what can help us focus in and think about cardiofaciocutaneous syndrome or other rhasopathies. So there's an overlap between these different conditions, where we know that there can be differences in how they present. So some may have bone involvement or growth and feeding problems. Some will have developmental delay or heart abnormalities, hematologic abnormalities or distinctive facial features, or skin involvement. And there's an overlap between them, but also distinct things about each of the conditions that separates them from the others. And I forgot at the beginning of my talk to dedicate my talk to Mariella Pierpont, who taught me everything that I knew about cardiofaciocutaneous syndrome and originally got me involved in caring for individuals with multiple different rhasopathies. And Mariella was a pioneer in the cardiology and the genetics of Noonan syndrome and other rhasopathies. So and then I had the pleasure of also working in the past with Dr. Noonan. And so some of these pictures have come from both of them in terms of the presentations that I give of individuals with cardiofaciocutaneous syndrome over time. So you as families with affected by cardiofaciocutaneous syndrome are well aware of this. I'm preaching to the choir, if you will, but 1 in 800,000 individuals, or between 200 and 300 people in the world. I think that's an underestimate. And it's affected the genes BRAF, MEK1/2, and KRAS, and as we've already talked about, the facial differences, congenital heart disease, and short stature. So I want to focus in on the growth retardation that's specific or focused in on CFC syndrome. So this is a study from 2011. There have been multiple studies that have shown growth failure with CFC, ranging from 60 to 75% of children being below the third percentile. And so in this slide, with the BRAF mutation, it was 63% of children had a height below the third percentile. 25 or 63% of children with a MEK variant had short stature. There was also absolute macrocephaly or large head, or relative macrocephaly, where the head was large for the body size. And growth failure during the first few years of life leads to a low mean adult height that is further compromised by delayed puberty and less of a growth spurt. But one of the challenges is that although we have condition-specific growth curves for some children and some disorders, including Noonan syndrome, we don't currently have a growth chart for individuals with CFC. And I'll show you some data about the the efforts were moving towards a growth curve that Tuesday talked about. So here are some curves in other conditions. So Turner syndrome is a genetic condition that affects the X chromosome of girls. And so in many girls with Turner syndrome, they're missing one of the X chromosomes or they're missing parts of the X chromosome. And what you'll see as a theme here is that we have the curve for typical children without the genetic condition plotted with the condition-specific ones plotted overlaying the typical curve. And so we can see for Turner syndrome that girls with Turner syndrome are significantly smaller than girls without Turner syndrome in the general population. And it's about 8 inches difference in girls with Turner syndrome. And interestingly, you can see the growth failure very early. And so there have been studies in girls with Turner syndrome to say, should we be treating them with growth hormone early to help fix the growth failure that happens early on to improve their ultimate adult height? Those studies have shown that treatment with growth hormone helps their adult height. It's still unclear as to whether treating them really early makes as much of a difference as if we caught them later. Costello syndrome. So this is an example of a growth curve that has been generated using 94 children with Costello syndrome. And we have males and females combined together on the curve. They were specifically not treated with growth hormone, so we didn't have the potential impact of growth hormone on what the curve would look like. And you can see again overlying the CDC curve that weight for children with Costello syndrome is overlying the bottom end of the CDC curve, and we needed. Not we, the team that developed this curve needed 1,400 data points to be able to generate this curve. And that doesn't mean 1,400 kids. That means of those 94 children, they had a combined 1,400 growth points that they could then use to generate this curve. And so that's what I'll talk about as we talk more about developing condition-specific growth curves. Tuesday talked about congenital disorders of glycosylation and say that 3 times fast. So my interest in rare diseases started very early in my career. Actually, my first rotation in medical school was pediatric neurology, and the first boy that I met on the hospital ward was a young man named Tommy that I still remember had ornithine carb, carb, carboxylase, I can't remember the name of the enzyme. He had a very bad disease, and it was a rare disease, and it got me interested from the beginning in pediatrics and in rare diseases. And I've been on the medical advisory board for the group for congenital disorders of glycosylation since I was a fellow, and we've been working for a long time on developing growth curves for these kids. And these are data that was published the year before I joined the University of Minnesota, and it was using 25 children and 550 data points, and you can see how wiggly those growth curves are. Partly, I think, because kids are hard to measure, and partly because kids do vary in their growth and have peaks where they're doing better and doing worse. So you'll see Kiki and Yao on a few of these slides. Kiki is my partner at the University of Minnesota. She is a endocrinologist and a genetics and metabolism expert, so she is a rare breed. Yao Otto trained at the University of Minnesota as an epidemiologist and is one of the few people in the world who knows how to create a growth curve and how to understand growth curves. And so we have been a dream team, in my opinion, trying to apply what we know about how kids grow to rare diseases. And Kiki's expertise is in congenital disorders of glycosylation, as well as congenital adrenal hyperplasia, which I'll talk about in a minute. So to develop the CDG growth curve, like the RASopathies, unfortunately, CDGs are a broad spectrum. There's probably more than 50 disorders of glycosylation. So we had to focus in on one of them to really get good data. And we collaborated with a rare disease consortium. So this is a National Institutes of Health RDCRN network funded consortium that partnered with CDG Cares, the patient advocacy group, to gather the data for these growth curves. This is hot off the presses. I'll give some unpublished data today, even though it's being recorded. Please don't share this. This has been submitted for publication, but again, in the dotted lines, we have the typical curve, the CDC or Centers for Disease Control curves that we use in the United States. And in the blue lines are boys with CDG PMM2. And we can see that the weight is also affected. And boys with CDG PMM2 have hypotonia, and so they have low muscle mass. So they have low weight and poor growth. We've done similar work, and this was just recently published in congenital adrenal hyperplasia. And actually, CAH is a condition where kids grow a little bit too fast early on because they're making too much of the hormones that can promote the growth plates to close. And they run out of time to grow and they don't have as much of a growth spurt as they should. And so in this situation, we can see that the growth curve is actually a little bit high earlier in life compared to the general population. And they end up being smaller than the general population, but quite a bit of overlap. And this is a population that has been well controlled and well treated for the duration of their care. We recently published, I guess it's now almost 2 years ago, a growth chart for Fanconi anemia. And Fanconi anemia is a DNA breakage disorder that we at the University of Minnesota see a number of children. We're a center of excellence for them. And this was similarly a family organization and Kids First Fund, which was a Fanconi anemia specific group. And so we were able to take 260 children from the University of Minnesota over 60 years, but we zoomed in on 125 of them that we had data for about 11 years. We used 13,000 clinic visits to be able to get enough data to develop our curves. And so with this condition, we were able to show that they were the 50th percentile for a child with Fanconi anemia was the third percentile for the general population for both boys and girls. And that was actually true for both the height and the weight in this situation. And so I think the power of the condition-specific curves is it can actually help us say, in Fanconi anemia, you're supposed to be skinny. We don't have to give you extra nutrition to try and fatten you up. You really don't have failure to thrive. You have Fanconi anemia, and you're supposed to be small. And that's really helped empower parents, not only to understand the condition better, but also to then advocate with their pediatricians to say, we're actually on the curve for the condition that my child has, and I'm less worried about how they're doing because it's the condition that's affecting them. And so I think that's one of the powers of a condition-specific growth curve. And so I'm continue to advocate that we get that for cardiofaciocutaneous syndrome. So here is also some unpublished data. So this was a project funded by the cardiofaciocutaneous international team through the National Organization for Rare Diseases. And Pilar Magoulis is a genetic counselor at Baylor, and Carrie Johnston was a genetic counseling student who was doing her thesis with Pilar at Baylor. And we took data that you guys provided from about 57 children with CFC syndrome. The challenges really are getting the data, extracting data from the growth curves, getting information about growth hormone therapy if it was used, and trying to interpret data that's all over the place because sometimes when kids are measured, they're just not measured well. And then generating the curves. And as I mentioned, we have to have expertise to do that. So here are the data plotted over the typical CDC curve from the US. And so you can see we have, as expected, we have more data in younger children. We can see that if we eyeball the curves, they look like they're tracking in the lower end of the height curve for the general population and then falling off the curve and ultimately ending up on the small side. However, here's an individual with CFC who's above average height. So there's definitely variability. Is this variability due to a milder form of CFC or really tall parents? We don't know. Was this child treated with growth hormone? I don't know the answer to that. So this is where we need to get more data to help us understand and hopefully generate more actual curves from the data. So this is now looking at, I mentioned standard deviation scores. So again, 0 is the 50th percentile here in the middle. -2 is the bottom end of the curve. So in 0 to 2 years, we see most of the kids still in the curve. Between 2 and 5, we see them start to fall off, and 5 to 10 fall off. And then the children for whom we have data in the teen years, they're higher on the curve, but still, -2 or slightly below on average. That's for height. For weight, so we see a similar a variation, but again, most of the people towards the bottom of the curve and then falling off the curve. And again, we see more kids below average, but still on the curve. Similar, but falling over time, where as they get older, they fall off the curve for weight. BMI is actually less affected until later years. So in younger years, we have a broader spectrum of BMIs, and then later they tend to be thin, but not under the curve. And that's reflected here with the bars for the standard deviation score for the BMI. So how does this all work? So I love this cartoon, a baby with lots of mucus. The pituitary was actually named for the Greek pituo, to spit, or pituita in Latin, which is mucus, because it lives right above the sinuses, and they really thought that it was making spit. So here's what the pituitary looks like sitting up above the sinuses. One of the jobs of the pituitary is to make growth hormone, regulated by the signals from the brain. Growth hormone goes into the blood. It tells the liver to make hormones called insulin-like growth factor, or IGF-1, and some other hormones that regulate it. And growth hormone also goes directly to the bone and tells the bones to get ready to grow. IGF-1 does most of the helping grow at the bones, but it's growth hormone and IGF-1 working together to help kids grow. So IGF-1 is a hormone like growth hormone. And so when we think about how it works at the cell, each cell, and this is the cell membrane, so that's the barrier between the inside of the cell and the outside of the cell, has these receptors or plugs on the surface that can only receive the right size plug. And so if you're in Australia, as some of our colleagues are, you know that your plug is different than the one in the US. That's the kind of receptacle that we're talking about here, is that you have to have the right receptor for growth hormone or for IGF-1 on the cells. And what they do is they turn on the system inside. And so when we think about the system inside that then tells us how to grow, that's where the RASopathies come in. So they're part of the system that sends the message from the receptor outside to the DNA inside that says it's time to help a child grow at the cellular level and at the hormone level. So, and the KRAS and HRAS and PTPN11 and SOS1 and BRAF and SHOC2. These are all some of the genes that we've been talking about, MEC down here, that cause cardiofaciocutaneous syndrome or other RASopathies. And so the challenge is, even though we're getting the signal up here, it's not being translated to the system to tell us to grow as well as it should because these parts of the system don't work like they should. They're either turned on or they're turned off, depending upon the specific condition. So in cardiofaciocutaneous syndrome, it's the BRAF, RAF, and MEC typically. So when we think about nutrition and IGF-1, I mentioned that growth hormone regulates IGF-1 production, but when you make growth hormone goes to the liver and says make IGF-1. But the liver is actually a very important nutrition sensing organ. And so if you don't have enough nutrition, the liver says, I'm not making IGF-1 today. So we're not going to grow today because I don't have enough nutrition. And so it's going to have a low IGF-1 just because we're either not eating enough or we're not absorbing it properly, or we have another problem that's affecting our ability to translate that signal. So one of the questions that we look at when we look at different rare diseases is how much of the poor growth is due to challenges with feeding issues, absorption issues, vomiting issues, and how much of it is a high metabolism. There are some conditions where we're just burning our calories. We take them in okay. Cystic fibrosis is a good example of that, where they have malabsorption, but they also have a high metabolism because of their condition. So growth failure in children with cardiofaciocutaneous syndrome is likely due to several issues, where it could be nutrition because of feeding challenges or malabsorption. And then the hormone abnormalities, growth hormone and IGF-1. Previous studies have shown that most children with CFC actually make growth hormone normally. If we do a growth hormone stimulation test to look, can they make growth hormone when they're supposed to? They do. So this would actually suggest a form of resistance to growth hormone. And that's what I was talking about at the cell level, where as the signal is coming into the cell, because the system underneath the receptor doesn't work right, it's not sending the signal downstream to the system. And there are a few children with CFC and other forms of restopathy, Noonan syndrome, where they do have low growth hormone levels. So I think we should still look for it, but it's not the most common cause of growth problems in children with CFC. And then, like other children, there can be abnormalities in the thyroid hormone system or sex hormones that regulate puberty. So, treatment to improve growth in individuals with CFC, we have to optimize nutrition. But as I mentioned, if it's normal for children with CFC to be on the lower part of the curve for weight, and we don't yet know that fully, whether that's just their nature or a combination of nutrition and other issues, we may not need more calories because they may be getting enough. They may be absorbing them appropriately. We have to rule out other causes of poor growth, cardiac dysfunction. If you have severe cardiac dysfunction and heart failure, you're not going to grow well. And that goes into that I need more calories than some other children might to grow. And then growth hormone therapy. If growth hormone deficiency is diagnosed, it's actually unclear if there would be a benefit in children with CFC without growth hormone deficiency, as has been seen in Noonan syndrome. And so Noonan syndrome is an FDA and European Union approved and other countries approved indication for Noonan syndrome or for growth hormone therapy, but it wasn't studied in individuals with CFC. Growth hormone is currently a daily injection given subcutaneously in most parts of the world. Very recently, the first one in 2020, once weekly growth hormone was approved for children with growth hormone deficiency and is actually expected to be approved for children with Noonan syndrome in the very near future in the United States. So there are once weekly products available for kids with growth hormone deficiency. There are some nuances to who should get weekly, who should get daily, but in general, we think that the weekly ones are as safe as and as effective as daily in the short term. We need longer term data. So what are the benefits of growth hormone therapy? So number one, taller, if the child responds and actually takes it. Number two is increased weight in most children. So when you're getting bigger, you're gaining muscle, you're gaining bone, you're gaining weight. It's not going to help somebody eat better. It increases muscle mass. It increases bone mineral density and it improves body composition because growth hormone, in addition to helping us grow, is actually a nutrient regulator that helps us decide, do we make muscle or do we store calories as fat? Do we make bone? Do we store calories as fat? There's some questions about whether growth hormone therapy can actually improve cognitive function. And in infants born small for gestational age who were treated after age 2, they showed a small increase in IQ, which is not enough to warrant therapy by itself. In children with Prader-Willi syndrome, they have growth hormone deficiency and very low muscle tone. Early treatment shows that they reach their motor milestones earlier, and it may lead to a long-term cognitive benefit, but it's been difficult to demonstrate. There's a specific rare disease called 18q minus, where there's deletion on the long arm of the 18th chromosome that increases those individuals' risk of growth hormone deficiency. And that condition is associated with a deficiency of the myelin coating on nerves that actually help the speed of how our nerves work and we transmit information. That stuff gets better in those specific individuals treated with growth hormone. And so they saw cognitive benefits in children receiving growth hormone with that condition. Um, so there's some suggestion that there may be some mild benefits in terms of muscle tone and motor milestones, and maybe even a small change in IQ. But in general, the benefits of growth hormone therapy focus on being taller. If you're severely growth hormone deficient, there may be some more. So whether growth hormone is beneficial in children with CFC is still one of the questions that led to the growth chart progress. And we need to have good comparative data in children not receiving growth hormone to know if they'll actually respond to growth hormone therapy. So what are the risks? So first of all, if you give growth hormone therapy to children, and these are the top risks are the risks for any child receiving growth hormone therapy. So number one, if you have scoliosis, it can get worse. And it's only because you're growing faster. Growth hormone isn't making somebody develop scoliosis, it's just worsening the angle because you're growing more. Intracranial hypertension is a rare side effect of kids receiving growth hormone, and it's basically buildup of pressure in the fluid surrounding the brain. And it's a temporary side effect of the growth hormone that can happen in a very rare side effect of the treatment. Slipped capitofemoral epiphysis is a long word to say that they have a fracture in the growth plate in the hip because they were growing so fast that the weak point was the growth plate, and with some trauma, they had a fracture there. So those are risks of kids growing faster on growth hormone therapy, regardless of their condition. There's a theoretical risk of having an increased risk of cancer because you're getting growth hormone. Growth hormone and IGF-1 don't make cells turn into cancer, but they help everything grow if there's already a cancer present. So there's been a lot of study in this area and some questions about rare diseases being at increased risk for cancers. Should we be treating them with growth hormone? In general, growth hormone hasn't been shown to have a true connection to cancer in the long term. And finally, more proximal to children with cardiofacial cutaneous syndrome is that there's been a lot of concern in Noonan syndrome that growth hormone could worsen hypertrophic cardiomyopathy. But these data are small, but growth hormone therapy hasn't been shown to increase the risk of developing hypertrophic cardiomyopathy or in those children who were receiving growth hormone worsening their cardiomyopathy. Again, small data, but very important questions that we continue to need to ask. So, what are the recommendations? So, if you're at risk for failure to thrive, short stature, growth hormone deficiency, growth hormone resistance, and delayed puberty, the recommendation is that you see one of us endocrinologists between the ages of 2 and 3 for growth monitoring, or early if there are concerns about growth. That we look at the hormones. Thyrotropin is the TSH thyroid regulator. Thyroxine is the thyroid hormone in the blood. These two are the growth hormone markers in the blood to look for the problems. Look at nutritional assessment and growth measures by your primary pediatrician or care provider. Monitor growth over time, and that can be done very well in your primary care office. But if there are concerns, and particularly if somebody's falling off the curve over time, follow up with the endocrinologist is really important. And continued screening for other potential causes of growth hormone, and then of growth, excuse me, growth failure. Um, If we are seeing growth failure over time, we may end up doing a growth hormone stimulation test, which is a specific test to say, can your child make enough growth hormone when they're supposed to? And we typically do that if the growth hormone markers, IGF-1 and binding protein, are low. So if they're not low, we probably don't need that test because the likelihood of a deficiency is low. And then we need to monitor pubertal development beginning around age 10, though maybe slightly earlier or slightly later, depending upon the family history as well. Um, Regulation of puberty, I'm going to talk about this just very briefly. I mentioned the pituitary's job on growth hormone. The signals from the hypothalamus down to the pituitary also regulate the signals to the gonads, the ovary, and the testicle to make testosterone and estrogen. There's a normal pattern of puberty that varies before you're born, a little spike shortly after you're born, and then a typical surge of those hormones when it's the appropriate age for children to start going into puberty. There's a range of when kids have the different signs for puberty that is true across the world in different ethnicities and different conditions. And that does vary based upon some of those features and upon your family history and upon the condition. And we know in CFC that it tends to be slightly later in most individuals. So, regulation of menstrual cycle in girls is very much regulated by this process of sending the hormones from the hypothalamus to the pituitary to the ovaries. There's a normal range. I showed the distribution curve of stature, and we have the same bell-shaped curve of the timing of onset of puberty. And if kids are really early or really late, we start to worry about conditions that are affecting the timing of their puberty. And so when we think is typical for the general population, if they're having puberty before they're 9 for boys, it's early and should be investigated. Less than 8 for girls. And some data says that some normal signs of puberty are happening as early as 6 or 7. We still think if it's happening in those ages that we should be paying closer attention to it. Menarche before the age of 10, and delays you can see 14 for boys, 13 for girls, and 16 for menarche in girls. So those are the ends of the spectrum where we start to get concerned. So if we look specifically at puberty in boys with CFC, we can have undescended testicles in the majority of boys, a few reports of early puberty, normal pubertal development in many children, delayed puberty is common, and then we can see some permanent decreased function in the testicles in adults. When we think about girls, there have been reported cases of precocious puberty, but delayed puberty is the most common. Absent puberty has been reported, and there have been pregnancies in individuals with CFC. So when we think about the treatments of puberty, I mentioned growth hormone treatment for growth disorders. There are treatments that if a child is not going through puberty appropriately, that we can intervene um, and help with that process. We also have to think about if girls need estrogen in CFC because they're not having puberty, that they may be at risk because of coagulation differences of complications of estrogen therapy. So something to also be aware of and pay attention to. And as mentioned by Tuesday, I'll focus on this in more in detail in a future talk. And testosterone, aside from making kids ornery, does have some other side effects. But in general, is helping to build muscle and build bone. So we need data on the timing of the physical signs in CFC. Um, we need data on the responses to sex steroid therapy, and we when we need to give it, we need to know what are the risks and benefits for children. So my take-home points. I tried to leave time for questions. I hope I haven't yammered too long here. So poor growth we know is part of the condition. If the IGF-1 is normal, then no growth hormone stimulation test is needed because the likelihood of a deficiency is low. And by normal, I mean IGF-1 above -1 standard deviation score. So it could still be in the normal range, but the low part of the normal range, there's some overlap with growth hormone deficiency. I didn't talk about a bone age, but it's a hand x-ray that helps us look at how much time children have left to grow. We look at the growth plates in the hand to say how much time is there. If a child with CFC has growth hormone deficiency, they will definitely benefit more from growth hormone treatment than if they're not deficient. Potential risks are cardiac. As I mentioned, the hypertrophic cardiomyopathy, there's a concern that growth hormone could make it worse. Our previous data doesn't say it predisposes someone to it, but it's still low data. No good evidence for a cognitive benefit. And as I mentioned, we now have some once weekly long-acting growth hormones that are available in children diagnosed with growth hormone deficiency. For puberty, if it's early, they may benefit from medication to suppress puberty. And if puberty is late, there may be some benefits of sex steroid therapy. And finally, I want to emphasize that even if we don't grow right, we are still perfect. And this is from the sister of a child with CDG PMM2 from the late 90s, actually. And then this is what Minneapolis looks like all year round. There's never snow here, I swear, or ice. And it's to emphasize that we're a rare disease center of excellence and also have a rare disease pharmacy center of excellence. And this is my contact information for afterwards. If people have questions, feel free to email me. But now I'll open it up for Tuesday to read the questions in the chat, and then we'll stop the recording and let people ask questions off camera or on camera, but off recording.
Thank you so much, Dr. Miller. That was absolutely wonderful. And yeah, I'll go ahead and start reading the questions off of the chat. If you are concerned about asking your question while we're recording, once we answer the questions in the chat, I will turn off the recording and you can ask questions in person that won't be a part of the recording. So we'll start with the first question. Which is can growth hormone cause aggression in children? Our 9-year-old child with CFC is on growth hormone and has been exhibiting aggressive behavior like hitting others, and we are seeing a behavioral therapist.
That is a great question. And it's come up a lot over my 20 plus years of treating children with growth hormone therapy. And in general, I would say no. We don't think that growth hormone has either a positive or a negative effect on behavior, but that's probably too simplistic an answer. I think if the injection process is traumatic, and the child has to be held down, or they don't adapt to the shots very quickly, then that could, tip the apple cart, if you will, and cause some surrounding behaviors. When I've seen that, usually behavioral therapies have been successful in extinguishing that behavior because typically shots don't hurt very much or for very long, and kids do adjust over time. It is possible that there are some changes with growth hormone therapy that affect mood, but in the number of children that I've cared for and my colleagues have cared for, we have, I think it's 600,000 patient years worth of data in large registries that included thousands of children, many of whom had rare diseases and some of whom had CFC. it hasn't been a signal that is clear that we know that growth hormone is making that change. That said, I have stopped growth hormone in a small number of children, not specifically with CFC, but where they did have behavioral changes. They got better when we stopped the growth hormone, and when we tried to restart it again later, the behavior came back. So there are some individual circumstances where I had to say, I don't know why, but growth hormone changed this child's behavior. So I would say in general, no, but small number of cases where it could be the culprit. Great question.
The next question is, can individual, uh, can individuals with CFC syndrome have issues maintaining glucose levels? My son is 16 months old and his sugar keeps bottoming out. Docs are puzzled and cannot seem to find a cause. Growth hormone testing is our next step. Can glucose issues and growth hormone deficiency go hand in hand? And I will just say before you start, that is
Mm.
actually, glucose levels, especially in infancy, is something we do hear repeatedly within CFC syndrome, the CFC syndrome community, anecdotally. So I will share that.
Yeah. So I have seen it in other RASopathies as well. Costello, some kids with Noonan syndrome. Um, and to answer your question, growth hormone deficiency, when it's severe, can be associated with hypoglycemia or low blood sugars. And so we do have children without any RASopathy who have severe congenital growth hormone deficiency who can have seizures because their glucose levels are so low. And giving growth hormone in those individuals actually treats the hypoglycemia. So, growth hormone regulates some of the proteins in the blood that help us keep our blood sugar stable. And it's much more noticeable in young children, infants up to maybe 3 or 4 years of age, where even those with severe growth hormone deficiency, if they don't get their growth hormone, don't have a blood sugar problem as they get older. But they're very, very susceptible to it in the younger ages. Um, that said, if the child does not have growth hormone deficiency, as Tuesday was saying, there's still a lot of children with CFC that have hypoglycemia, and unfortunately, it's difficult for us to figure out a cause. Some of the reasons we see low blood sugars in children are related to how we feed them. So some children with G tubes who are receiving feedings through a G tube may be prone to blood sugar problems over time because of uh, the way we are feeding them, whether we're doing continuous or bolus feeds, or if we've done continuous for a while and transition to bolus feeds. And so, if they have slow transit, then their body is seeing lots of sugar and then no sugar, and so the pancreas gets overzealous and makes a little too much insulin, and then the blood sugar falls after the sugar is gone. And so there are a lot of different potential causes, but I'll echo Tuesday to say I don't think we've found a cause in lots of children with different RASopathies, and it's been quite frustrating. We have we tend to think of hypoglycemia as dangerous to brain development. When the blood sugar gets below 50, we start to worry that our brain isn't getting the sugar that it needs. Above 50, we think that the brain compensates, and so that's kind of the area where we think about the safe zone, if you will, above that. But growth hormone's part of it, but not the cause in most.
Thank you. The next question is, how does growth hormone affect children, and can it improve other systems like muscular development, stamina, endurance, neurological development, cognitive development, motor responses, and sensory processing?
So I touched on this a little bit in my talk. We definitely see in kids with hypotonia, if you're starting growth hormone early, in the first 2 years of life, I think that you can see a muscle benefit and a motor milestone benefit in some of the children. Um, and that may lead to improvements in their cognitive development, but the improvements are small and hard to measure over the long term. When I have patients with hypotonia who have short stature, and particularly if they have growth hormone deficiency, I'm like, we need to get this started very, very soon. And I mentioned Prader-Willi syndrome, which is a condition with severe hypotonia or low muscle tone. And to me, although they are truly growth hormone deficient, their real benefit is their improvement in muscle tone in that condition. So I think hypotonia should be a reason that we should think about growth hormone in children with different rare conditions. The question is, how long is that benefit? I mentioned that we definitely see gains in those first 2 years of life. After that, it's harder to really quantify. Are we still seeing it? And is the benefit that we had early on long lasting? Neurologically, the studies are so small to say, is there a long-term benefit from the growth hormone? I mentioned children who were born small for gestational age. They, in general, are not hypotonic, but for some reason, there's a small IQ benefit if we look over the long term of their treatment. Um, and I'd take another IQ point if I could get one, but we don't know how many children will get them and how many they will get in terms of the growth hormone response. So I don't think cognitive benefit should be one of our thoughts with growth hormone treatment, that it's truly going to be the reason to start. There should be other rationale.
And to add to that question, for a toddler with low IQ who's using growth hormone, how long would it take to see any benefit cognitively, if there was going to be a benefit?
Yeah, that's hard to measure, but as I was saying, the cognitive benefits that I might expect would be related to improvement in their ability to explore their environment from the muscle gain. So their motor milestones would be first, and any associated cognitive benefit would be related to that motor gain. And like I said, it's hard to know if that's a permanent gain that is measurable and attributable to growth hormone by itself.
The next question we have is what age growth hormone therapy normally ceases?
Ceases. So we treat children with growth hormone therapy in until they're done growing. Um, and that is typically defined by the growth velocity slowing down to less than an inch per year, or the growth plates on the X-ray being closed, or both. Um, However, in children with severe growth hormone deficiency, they may need to be treated for their whole life. So there are a small number of children who have congenital growth hormone deficiency or multiple pituitary hormone problems uh, that benefit from growth hormone lifelong. There are also adults who've had a pituitary tumor or radiation to their pituitary hypothalamus that don't make growth hormone who also benefit from growth hormone. And in adults, it's improving muscle mass. It's improving, as someone asked earlier, stamina. It's improving bone health and bone quality and energy levels. And if you ask individuals, quality of life improves as well. The number of days they go to work, the number of um, times they're out exercising, etc., all improve when they're on the growth hormone versus not. But these are individuals who make very, very little growth hormone as adults, and it's those metabolic benefits that we're seeing.
Thank you. The next question, in a lot of ways, has been answered by the information that you have shared. So I just want to go ahead and read it, make sure we touch on any parts that might be additional from this question. What is the general timeline to see results or outcomes? And for pre-puberty CFC kiddos, up to about what age is growth hormone indicated? And so you just kind of answered that
Yeah,
question about how long someone might stay on growth hormone, but what the general timeline might be prior to
yeah.
puberty might be helpful.
So, in general, when we're looking at growth in response to growth hormone and both weight gain and length or height, um, by 6 months of treatment, you can clearly start to see gains. And so, at a year, you can definitely see children getting closer to the curve than they were before. So typically with growth hormone therapy in where we have more data, Noonan syndrome or growth hormone deficiency, that first year we consider catch-up growth, where they're catching up to the curve. So getting closer to the curve. And most children on treatment who are responding well to therapy will show catching up over the first 12 to 24 months, where they're climbing the curve. I point directly up, but usually it's more at an angle. Um, and then they'll level off. They won't necessarily now follow that new channel specifically, but if they're gaining ground on the curve, they're gaining it slower after that first year or two of treatment. And if you were to stop treatment, so let's say you started treatment in a child at age 2 and treated them to age 5, and they're now on the typical curve. If you then stopped treatment at age 5, they're going to drift back to where they were on the curve before. Unfortunately, those gains aren't permanent. So you actually have to continue the treatment to be able to continue to gain growth. And so typically they'll follow that new curve over time, and then depending upon the timing of puberty, they may drift a little bit if puberty's late, and then have a little bit of a growth spurt as they're making their puberty hormones. So when we think of treatment for height, we want to be as long before puberty as we can, because as I mentioned, you don't gain much once you hit puberty on the curve. So you'd like a couple of years before puberty happens to actually show that catch-up growth, to get up towards the curve or onto the curve, so that when puberty does happen, you're able to maintain your spot on the curve as you go through.
Thank you. The next question is related to an individual on the call who was diagnosed with CFC syndrome, a MEC2 mutation, at the same time as their child who was diagnosed near infancy with CFC
Mhm.
syndrome with a MEC2 mutation as well. The adult is missing a fallopian tube, and their uterus is extremely small, and they're wondering if this could
Mhm.
be related to growth hormone and what the risk would be for their child of having the same issue because they share the same variant.
Yeah. So the difference in the uterine size and the missing fallopian tube, I honestly don't know what the risk of that is for the infant with it being present in the child with the same variant. So it's a great question. I don't think that they're connected with growth hormone production in the individual. I think that'd be more a specific problem with the development of the uterus and the fallopian tube. So I don't think growth hormone would have a risk of changing that in the infant if the infant were treated with growth hormone if that was deemed appropriate.
The next question is that their child has failure to thrive, low weight gain, slow growth, failure to thrive. They have feeding issues and vomiting, but most recently had unexplained persistent fevers constantly for 3 months. And they're wondering if these persistent fevers are somehow connected to this and growth hormone deficiency.
So not connected to growth hormone deficiency. The fever shouldn't be connected to growth hormone deficiency in any way. Um, The failure to thrive can be a feature of cardiofaciocutaneous syndrome. It can be present in somebody with growth hormone deficiency. Um, we used to think that failure to thrive sort of was completely separate, and uh, kids with growth hormone deficiency typically are chubby because they're not using their growth hormone to build to grow, so they tend to be the term is cherubic. They look like Cupid. Um, so little chubby babies because they're not using the growth hormone to grow. But we found in many different conditions that failure to thrive because of a genetic problem could also be associated with growth hormone deficiency. So not necessarily the cause, but the condition causes both of them, if you will. Um, so the vomiting, unfortunately, can lead to failure to thrive. And so, as I mentioned earlier, when we're trying to sort out, does a child have a growth hormone problem, vomiting, malnutrition, malabsorption can all lead to low growth hormone markers that may not be because you don't make growth hormone well. They're because you're not well nourished. And so I think continuing to work with the gastroenterologist, the geneticist, maybe even the endocrinologist to sort out how we can fix the vomiting and the feeding challenges will then help us understand, can this child grow better? The fevers, I don't have a good answer for that. It seems to be a separate part of the situation that I can't connect.
The final question, or sorry, let me see. There's actually another two more questions that have popped up. They have a 3.5-year-old daughter who they happen, and all of a sudden I see I need to pop down and read them. So,
Totally
they have
fine.
a they have a 3.5-year-old daughter who's 28 pounds and has MAP2K1 mutation with low IGCF one, and only feeds by Pediasure by
Mhm.
bottle. They were looking to explore treatment, but they're nonverbal. What are some of the side effects or benefits of growth hormone at her age? The child is nonverbal. I should have clarified that and read the question correctly, but I'm sure you assume that. The child is nonverbal, um, and they're wondering what the side effects and benefits of growth hormone would be
Yeah.
at her age.
So, I, when we think about growth hormone treatment in any child, we number one, as I mentioned earlier, we want to see if they are deficient or not. And the low IGF-1 could point to the fact that they're deficient, but isn't a guarantee. And that's where that growth hormone stimulation test comes in. Sometimes the IGF-1 is low, but they're making normal amounts of growth hormone. And in those children, they're less likely to benefit from growth hormone therapies. So, um, in general, when I think of either Noonan syndrome or CFC or Costello, I think of them as having IGF-1 being low, and only a very small portion of the children having it low because of the growth hormone production problem. More of them, they're resistant. They're making as much growth hormone or more than other children, but because of that signaling block in the system, their IGF-1 is low. And we don't have a good thing to fix that. Growth hormone may fix it, like it does in Noonan syndrome, by basically giving extra growth hormone to help kids grow. In that situation, the only benefit that I would perceive is height. And so if your child is nonverbal and being 2 inches taller when they're done growing is not going to be that important, then I think that's a big part of the conversation as to whether you think it's an appropriate thing um, to do growth hormone therapy. If they're deficient, that's another story because there can be benefits in muscle tone, there could be benefits in bone health, there could be benefits in their heart. So I think it's a challenge to say where where do we decide it's a benefit for each individual child in their specific circumstances. And because it's a daily injection, that's also or a weekly, even if it's a weekly injection, that's also something that you then have to do regularly. And although it's quite well tolerated, if you don't need it, and if your child's not going to benefit from it, you don't want to do it.
The final question we have in the chat is for the growth simulation test, what is considered as failure?
Hmm. That is a loaded question because it's different in every part of the world, and there are differences. So, in the United States in general, people think that if you peak under 10, and that means none of the growth hormone values go above 10, that you have growth hormone deficiency. Most people in the United States would say 10 is generous, and they would more likely use 7 as their threshold. I know in parts of Australia it's below 3. I know in most of Europe it's 6 or 7. It depends on the country, and it also depends on the specific assay in the hospital that you're in. But in general, the lower the number that is the peak, the more that we're worried that you have a severe growth hormone deficiency and could have low blood sugars if you're young, or other metabolic problems related to the growth hormone deficiency, and would have a higher need or warrant therapy for growth hormone treatment. And so, but that number does vary across the world right now. We wish it
And
was a better test.
it looks like mom has indicated that their highest point has been 3.4.
So 3.4 in our assay would be quite low, and it would make me want to do imaging of the pituitary gland to see if it developed appropriately. Um, uh, but as I mentioned, I think depending upon where you are, it might need to be less than 3 for them to consider you truly deficient. But most parts of the world would say a 3.4 is deficient. And so, as I mentioned, would benefit from treatment not only from growth, but potentially the muscle mass, the bone health, other things as well.
We are going to stop recording at this point, Dr. Miller, so we can go ahead and let any additional questions off of the recording be asked. So I'm going to stop that.